We're pretty lucky now, lucky due to a lot of many international trials and efforts of people everywhere in Europe and the States, that we can cure now about 90% of children with leukemia. When I say leukemia, I mean ALL, acute lymphoblastic leukemia. So we actually have two main challenges now. One is to cure all leukemias. I mean, you can't imagine a mother that you tell her, you know, it's fantastic, we have 90% chance to cure your child leukemia. We want to cure all of them. So we focus on high-risk groups. And then the second challenge is to reduce toxicity, immediate and long-term toxicity. And this comes from targeted therapy. So targeting therapy. So genomics assists in solving both problems. So I'm talking here mainly on the discoveries of kinase-driven leukemias that are more commonly called now Philadelphia-like or BCR-ABL-like leukemias, but they are actually kinase-driven leukemia. And I talk mainly not on the ABL side, but on the majority of the leukemias, they are driven by the JAK-STAT pathways. A pathway that we and others discovered involved in ALL, and for which clinical trials now with JAK inhibitors have just begun in the Children's Oncology Group in the United States and also in adults in MD Anderson. Another problem that a clinician have. So the clinicians now are overwhelmed with genomics. There are so many mutations and aberrations, etc. And the question, well, what is the clinical meaning of all these findings? So clinical relevant mutations are those that have independent prognostic significance or can be targeted and for which there is a diagnostic test. So for example, the kinase-driven ALLs is one example. Another example is deletions in Icarus that entered the risk stratification scheme, the risk stratification stream now in clinical trials. Another emerging example comes from the analysis of paired leukemia samples in diagnosis and relapse, in which relapse-driving mutations are being discovered. So most of the significant mutations at relapse exist in a small clone, a diagnosis. So if this research will eventually lead to identification of targetable lesions that drive relapse, and we may diagnose them at diagnosis, we may identify patients that can be targeted already at diagnosis. Some of this research is being applied actually already now. So targeted therapy of Philadelphia-like or kinase-driven leukemias is already in clinical trials. So it becomes a routine. It is becoming a routine now to apply a diagnostic scheme to identify these patients. We now understand better, and I will talk about it today, how when Icarus deletion can and why they cannot be used for stratifying patients. What drives relapse is still, I believe, in earlier phase of research. So it's still research and not something that can be translated tomorrow or today into management. First, that genomic is really meaningful. And this group of kinase-driven leukemias is a group that probably can be targeted and their prognosis can be significantly improved. And the second take-home message is actually about being a bit careful. One should be careful from very quickly ascribing prognostic significance to new findings, because prognosis is first and foremost dependent on therapy. So one lesion can have different prognostic relevance in different protocols. And then it may also depend on the context of leukemia. So a specific lesion, Icarus deletion for example, may have prognostic significance in one type of leukemia, but not in the other. So especially clinicians, when our slogan is primum non nocere, first of all, don't do harm, should be careful before adopting a new genomic findings that appears in Nature, appeared in Nature yesterday. We are in a very exciting time. We see very fast developments and very significant improvement in outcome of both children and adults with hematopoietic malignancies.